Professor Zhong and Professor Kim and ladies and gentlemen, it's my honor to present this topic and pros and cons in coronary imaging mortality, IVUS and OCT. I'm Wei-Chun Huang from Taiwan. First part I will mention about the intravascular image and also IVUS and the OCT. So for intravascular image, we can see the Korea group very excellent study in the Novate compared PCI. From this presentation part mentioned in ACC 2023. So focus on target vessel failure. So we can see the result. We can see the divide the patient into the image guide and the angio guide PCI. So we can see the angio guide PCI has higher mass than the image guide PCI for 3 years follow up. And also compare with OCT and the angio guide PCI, we can see the OCT guide PCI has less mass than the angio guide PCI. And also in the IVUS group, we can see the IVUS group also have a better outcome than the angio guide PCI. And how about the OCT versus IVUS? So we can see the OCT actually had less mass than IVUS in 3 years follow-up, but that's the only trend, not significant. And I think the patient, the includes patient is complex coronary artery lesion. So they collect more than 1,600 patients. About 50% is acute coronary syndrome. So for the subgroup study, we can see in stable ischemic heart disease, actually the image guide is more important, and also acute coronary syndrome has also better than the angio guide, although the statistics is not significant. And they divide patient into the complex lesion figure. For less than 3 complex lesion figure, actually angio guide is also better than IVUS guide, and also IVI guide also better than angio guide. And if the patient have more than 3 complex lesion figure, actually the result even better for the IVI image guide. So we can see if the patient have more complex region, actually IVI, the rule of IVI guide is more important in this kind of patient. And so how about the IVUS guide? For CAMIA study, Wei-Chun Kim published paper in JHA. So for the target lesion failure, we can see for the about 3 years follow-up, actually, the IVUS guide has less target vessel lesion failure. And also for the mass, we can see the IVUS guide at about 13%, but the angio guide about 16%. And for Lancet publication about the IVUS ACS 2-stage multi-center randomized study. So we can see the result follow-up 1 year. We can see the target vessel failure for the IVUS guide has less than the angio guide. And also in the target vessel failure without procedural MI, also the IVUS guide has less about 2.2% in 1 year's follow-up. And the patient, we can see the collect more population is Chinese people, and the unstable angina patient about 33%, and the non-STEMI 32%, about STEMI about 27%. So we can see in the presentation, however, unstable angina or non-STEMI STEMI, we can see the IVUS guide has better result than the angio guide. Although the non-STEMI, we can see is not significant. And how about the data from American because the problem is the penetration rate of IVUS in daily practice is very low. So we can see the American data from Medicare in collect 1.8 million PCI without IVUS or not. We can see the IVUS usage rate in unstable angina about 6.3%, and the ACS in total only 5% use IVUS. Yeah, how about in UK? In UK, we can see they use image guide. They increased the use of image guide from 2006 to 2016, however in IVUS or OCT. But actually, even in 2019, you can see the IVUS guide image about less than 10%. And also OCT guide is about 4%, less than 4%. So only about 14% patient will use this image to in the daily practice. So for the collect study use of image, we can see use IVUS guide image has less in-hospital mortality and less in-hospital mass. It's the same as OCT or combined IVUS OCT. So in UK study show the penetration rate in the UK is still very low, but if you use IVUS OCT, it's better, it can get a better result than the angio guide. In Japan, we can see the result from 7 institutes in Japan community in ACS patient to 625 patient, STEMI patient, about 51%. So 60% use image guide, and another patient use angio guide. So we can see the image guide has less cardiac event rate than the angio guide from Japanese data. So how about the OCT? Actually, in OCT, we can see the OCT can, in the capillary region of ACS, can detect and differentiate red and white thrombus to identify the erosion. So it's very important in the ACS patient. So the SKY expert consensus they mentioned about compare with the IVUS and OCT. So we can see the OCT can get a better result to identify the syncap, fibroadenoma, thrombus, and plaque rupture, and also calcium nodule. And also has better image than to perform the stent optimization for expansion or opposition. And also for the stent failure patient, we can see for OCT can identify more under expansion and also malposition. Of course, we know the IVUS will not induce the renal impairment, but OCT you have to use the contrast injection. Sometimes we will use glucose water to injection to flush all the blood away. And for previous study, we can see the use of OCT randomized study compared with angio guide. We can see the OCT has a better result than the angio guide. And also for non-STEMI patient in randomized another study, doctor study also shows the same result. So for the OCT study, we can get more optimization when doing the PCI for ACS patient or CAD patient. We can see the occupancy study actually from the Korea group in publishing Lancet 2024. They use OCT compares angio in compressed region. So the compressed region, including the CTO and also acute myocardial infarction as well. And we can see the OCT guide PCI in 1 year follow-up about 4.6 cumulative incidence of the mass, including the cardiac death, MI and ST, and also target vessel revascularization in 1 year. So the OCT actually is better than angio guide in the occupancy study. So they collect about 20% of acute MI in this patient, and also includes the CTO and the diffuse lung lesion, and also bifurcation lesion, and also protect the lemon artery disease. So they correct the patient with acute coronary syndrome about 50% in each group, and including the unstable angina, most unstable angina about 30%, and mine about 20%. So from the result, we can see the stent optimization and the clinical outcome in the OCT PCI groups. So we can see patient with stent optimization and also another group with stent suboptimization. We can see the difference of the stent optimization and without optimization. So the OCT can provide a better image to perform the stent properly. So we see another OCT ACS study for correct 100 non-STEMI ACS patient compared with OCT and angio. It's a randomized control study. So we can see the OCT can detect the acute malapposition stroke about 3.4%. In 6-year follow-up, 6 months follow-up, we can see the uncovered stroke can also identify, and also can follow up the complete the cover the stroke or not. So we can see the OCT has a better result than angio guided image in the OCT ACS study. And in erosion 3 study, we can see they collected about 200 STEMI patients use the OCT compared with angio guide. So in this study, we can see the stent implantation rate actually is increased, has a better in OCT guide. So also can in OCT we can save and also reduce the stent implantation. So stent implantation actually lower than the angio guide. So for use OCT you can put the less stent than the angio guide. For the doctor OCT doctor study in the ACS patient, they compare with the OCT and the angio guide in non-STEMI patient. So in non-STEMI patient, we can see the OCT guide has a better result than the angio guide in the FFR measurement. Comparable with FFR measurement, use OCT guide. And in the PSM cohort, they collected more than 3,000 patients STEMI, use the OCT guide and the angio guide. For the STEMI patient, actually, we can get the low mortality rate. So this is the angio guide, this is OCT guide. So angio guide has higher mortality rate than the OCT guide patient in 1 year, 3 years, and even 5 years follow-up. And there's another meta-analysis publishing in 2024. So in ACS patient, they collected a study about 2,000 patients in ACS patient, compared with the OCT and the angio guide, including the all cause of death, severe death, MI, TVR, and TLR. So we can see in ACS, actually, OCT can have a better result than angio guide in low mass. The most important, I think, get from the CV death and also target vessel revascularization. For the all-cause death, actually is no difference. And I think for the OCT, the optimized criteria, we can know that OCT can perform better imaging than age dissection, also stent expansion, and also stent opposition. So we can get more stent optimization for this patient. But now in Taiwan, the Korea girl in Taiwan is very popular, especially in baseball game. So many Korean girls come to Taiwan to performance. So they also are very welcome in Taiwan. So for OCT image, just like this image, so we can see very clear. But for IVUS, sometimes maybe you can use a little bit image. And for eagle eye, you can see not so many clear. So for me, image, how about the IVUS compared with OCT? Which image is better? So we can see some of study in recently published in Urinary Prevention 2024 for opinion ACS study. They collect 158 ACS patients, STEMI about 55%. And they compare with the patient in OCT or IVUS guide for different group. So we can see the 8 months follow-up actually instant MRA follow-up, we can see the OCT guide actually is similar to IVUS guide, OCT compared with IVUS. So in this result, it shows there's no difference in AUS follow-up for the instant lesion. And how about the OTIVUS sub-analysis compared with OCT and IVUS in CAD? ACS about 23%. For we can see the 2-year target vessel failure actually for OCT guide and the IVUS guide actually is very similar for ACS patient. Even the non-ACS patient, actually OCT look smaller, but actually there's no significant difference for this patient. But for the contrast-induced nephropathy, actually there's no difference in ACS, also in non-ACS. In Taiwan group, recently with publication in JACC Asians 2024, we collect 4,000 ESRD patients, including the ACS about 31%. So we can see we follow the patient about 4 years. So in the OCT guide and also IVUS guide, actually is not so difference in this patient in MACE outcome follow-up. We can see the guideline in ES guideline show if the patient have a clear carpet lesion, we can use image guide as a two-way indication. But if no clear carpet lesion like a MINOCA, so the IVUS actually, or OCT actually is a better image to identify, including the erosion, nodule, rupture, spontaneous dissection, or no lesion. So we can see the OCT, October RCT study compared with OCT angio guide in the bifurcation lesion. Actually, in the ACS patient, about 45% ACS patient. However, with ACS or non-ACS, actually, or bifurcation lesion, the OCT guide has better image than angio guide with lower mass, especially in no ACS patient. We show a case of STEMI cases with the total occlusion from RCS middle. So we use a stent thrombus aspiration. We remove the massive thrombus. So finally, without stenting, we can see we have a chemistry flow, but still have a hesitance for this lesion. So we decide to perform the use of 2B3 inhibitor for this patient. After 4 days follow-up, still have some hesitance for this patient. So we did the OCT for this patient, so we can see there's a big thrombus still exists in this part. So after the IVUS OCT, so we delete the stenting for this patient, so we can get a better result and use OCT to follow up. So one more thing, there's more Korean come to Taiwan, and I think maybe they get more salary than in Korea. So maybe Korea should be good at this this girl. And I think in OCT there's a pro and pros in OCT or IVUS in different situations. In couple ACS, OCT is better for spontaneous dissection or aorta lesion and lemon lesion. Coronary CT or IVUS is better, and the stent failure maybe OCT is better. Coronary renal insufficiency, maybe we should choose IVUS. However, in both of IVUS, ACT or not available, either IVUS or OCT can provide information than angio. we conclusion with Gary Means in TCT 2019 slide. So the argument is not the IVUS OCT, but the image guide stenting versus angio guide. And 80% of your PCI guiding need either IVUS or OCT. Another 10 or 20% depend on your practice and the region, IC. Which one is the IVUS or OCT is better? And welcome to Taipei next year. We have a Global AMI Congress in March 7 and 8. Thanks so much for your attention.